Hi, Adult Health One. So this is respiratory 5B. So it's still module 5. It's the second week of module 5. So it's the respiratory upper and lower disorders. Okay. So remember when we talk about disorders, the biggest thing is what do we do as a nurse? All right. So when you're going back and studying all of this, I mean, it's important to have an idea of what is going on in the disease process, because that is then going to dictate how we treat the disease process. But what we want to learn is how to safely take care of these patients, okay? So this is only 43 slides, so it shouldn't be too bad. And here we go. We're going to start with upper respiratory disorders, okay? All right, so rhinitis. Rhinitis, inflammation of the nose and sinuses, right? Affecting 20% of the population, not really life-threatening, but it can be annoying. You know, sleep disturbances, headaches, that sort of thing. It's classified as allergic or non-allergic, and unfortunately, it can be acute or chronic. So it's inflammation and irritation of the mucous membranes lining the nose. If you've ever suffered from this, you know it can affect the eyes, throat, and ears, right? It's categorized as perennial or seasonal, so all throughout the year or just, you know, at certain times of the year. It occurs in response to allergens. These can be environmental, medications, food, maybe even occupational, right? Common environmentals are like mold, dust, mites, cockroach droppings, so that's lovely. Weeds, trees, animal dander, foods, you know, we have our peanuts, our milk, wheat, that sort of thing. Medications, ACE inhibitors, like lisinopril and whatnot. One of the side effects of lisinopril is like a cough, just this weirdo low grade cough. And then of course we talk about penicillins. You can have sensitivities to aspirins, NSAIDs, all of that sort of stuff, right? So mechanical obstruction with the nose or sinuses can occur, right? So we would be thinking like polyps, nasal septal deviation, hypertrophy of the nasal turbinate or sinus tumors, and these can lead to rhinitis as well. So if you have something physiological going on up in the nasal cavity, you can end up with rhinitis. Non-allergic rhinitis presents pretty much the same. Most common cause is the cold, right? Rhinitis is a runny nose, essentially, and inflammation up there. Don't forget when we have inflammation, you know, the body throws all these fluids at it and stuff, okay? So pharmacological for allergic and non-allergic, you know, maybe decongestants, antihistamines. We have our nasal sprays, maybe even some corticosteroids just to take down that inflammation. Some of the biggest things to remember with like decongestant meds and whatnot is they can affect blood pressure. And with our nasal sprays, you can get rebound congestion. So we don't want to use nasal sprays all the time. If somebody has glaucoma or heart disease, we want to make sure that people are running these medications by their physician. Okay. Assessments for rhinitis, obviously we're going to do the vitals. We're going to look at elevations in heart rate, maybe temp, just to make sure that we're not dealing with some sort of infection here. You know, is the nasal drainage thin and clear or is it yellow? Teaching is just going to talk about appropriate use of the medications, and then decongestants, nasal like sprays and whatnot, like 2 to 3 days at a time, right? Just to avoid that rebound congestion. That's probably the biggest thing with that. And of course, if this is an allergy, avoid the allergen, right? We always talk about that. Rhinosinusitis is when we get the paranasal cavities involved. It's the preferred term now to sinusitis. because it kind of covers the whole thing, right? This can be acute or chronic as well. That would be super annoying. Um, let's see, just talking about diagnosing, kind of the same idea as rhinitis, right? The one thing with rhinosinusitis, because we get all the sinuses involved, you can end up with like facial pain and pressure, you know, the temples, the orbital area. People can end up with headaches, that sort of thing. And if it's infectious, of course, we may see some of a fever. You can end up even with maxillary dental pain, like back in here, because the ears can be involved. Um, so again, we just want to check for that purulent drainage just to make sure that we're not dealing with an infection. The drainage should be clear, thin, that sort of thing. One of the biggest things that can work for rhinosinusitis that is not a medication is normal saline irrigation. There's like the neti pot where you pour the little teapot up your nose. There's spray things that you can pretty much buy anywhere. So we would do teaching. One of the things we do as nurses is teach about saline irrigation. It helps reduce the salt water, helps reduce inflammation, and it also flushes out any antigens that may be hanging out in there, and further annoying those mucous membranes. So believe it or not, here's some complications. All right. Um, it can lead to osteomyelitis, meningitis. You can get an orbital abscess with this, sepsis, and subdural abscess. So there's some real life things that can happen to rhinosinusitis. If it is a chronic condition, if it goes infectious. So even though it seems like, well, it's just a sinus headache, just a runny nose, if we have green snot, or thicker snot, whatever, you do want to encourage people to have that checked out. Because again, osteomyelitis, meningitis, sepsis, and then orbital or subdural abscesses, that's no good. So our assessment, same as usual, vitals, you know, the whole thing. Physical exam, you know, we're going to look at mouth, nose, and face. You could have swelling like through here because of the inflammation. That is definitely possible. They could be tender around there. We are going to look for like abscess and cellulitis. Cellulitis, you know, is inflammation at the cellular level, and then abscesses are where we get pockets of pus and whatnot. So we're just going to want to monitor for that. You can percuss the sinuses. You know, are they tender? Do they sound full? Is it a dull sound? Whatever. We're going to administer meds as prescribed, right? So really the same old things, but add in some like normal saline rinse. And honestly, normal saline rinse could work for rhinitis as well. That would be fine. Teaching, we're going to talk to them about looking for signs or symptoms of infection, because anytime you've got fluid sitting anywhere, you know, lungs, sinuses, nose, or, you know, anytime you've got fluid, you run the risk of secondary bacterial infection, because it's this warm, moist area. Bacteria is going to be like, yes, please. So that's when we worry about that osteomyelitis and meningitis and that sort of thing. So we want to teach them to look for those signs and symptoms. Again, talking about like the decongestants, if you're taking a cough med and a decongestant, make sure that you're not over taking decongestants. Same with Tylenol, right? Acetaminophen, and even your NSAIDs. The decongestants can have all sorts of things. That's about it with that, right? Just flush everything out. This is a safety alert out of the book. It's talking about over-the-counter medications and just looking at the active ingredients, right? Making sure that you're not doubling up on certain medications, because they may be in your cough med, they may be in your nasal spray, you know, all that stuff. This talks about obstructive sleep apnea. So obstructive sleep apnea is a condition where the upper airway is obstructed during sleep. So this causes a narrowing of one or more sites of the upper airway. And what happens is these people end up with these like intermittent breathing patterns. If you've ever slept next to somebody with sleep apnea, it's super crazy because they will literally stop breathing. Okay. And then you're not sleeping so great because you're like, is he dead? Who knows, right? So they end up with these intermittent breathing patterns. This definitely affects males more than females. Um, One of the things with this, so if you stop breathing, you run the risk of hypoxia. So a lot of times this can end up with cardiac events because you go into a state of hypoxia. They call it apnea, right? Periods of apnea. There's no movement in or out, no gas exchange. So it's a hypoxic moment while you're sleeping, and you can end up with cardiac events. So risk factors for this, if you already have a history of AFib, if you have any nocturnal dysrhythmias, type 2, diabetes, heart failure, pulmonary stuff. One of the other big things is if you are overweight, because think about if you're overweight, you have a lot more adipose tissue around your neck. So when you're laying down, it's more likely for that adipose tissue to kind of move, shift back, right? Gravity kind of pulls it down, whatever, and can work to obstruct that airway. We also talk about cigarette smoking, alcohol use, 40 to 65. If you have any craniofacial or upper airway abnormalities, and then menopause, just throwing that in for fun, right? So your person's going to have loud snoring. They may snort. You may witness periods of apnea. They may gasp. You know, a lot of times they'll have a period of apnea and then they'll be like, right, wake themselves up. And that's the brain going, hey, we don't have any oxygen. You need to startle, come out of this, right? Um, so nocturnal restlessness or choking. They may be tired during the day. Fatigue during the day is one of the biggest things because they're not sleeping well at night. If your body's constantly bringing you up out of these apneic states, you're not ever getting into REM and you're not having a restful sleep by any means. Um, they may nap during the day, that sort of thing. They may have like cognitive, there we go, cognitive disabilities during the day. They may feel foggy, anything exactly like when you don't get enough sleep, right? Same deal. Diagnostics, so they're going to go in and talk about a sleep history. They're going to talk about sleep patterns. Do they snore? A lot of times the patient's like, I don't snore. And the partner's like, yeah, you do. They're going to talk about daytime sleepiness. Polysomnography is the word for a sleep study. So a lot of back in the day, you used to have to go to the clinic, do the sleep study. People didn't sleep that great anyway. It's not your normal environment. You've got things attached to your head. You've got things attached to your chest. Now, a lot of times they'll let people do a sleep study at home. So it's a lot more like imitating your normal sleep patterns, right? So they can get a better read on what's going on with people. Treatment, first thing, if people are overweight, lose weight. Okay, that's one of the biggest things. But people can go home with a CPAP and you wear the CPAP at night. There's different options for masks. There's even one now, I don't know how it works, but I've seen the commercial where they put some sort of stimulator in your chest and you activate it at night, which is super interesting because that gets rid of the whole, machinery. A CPAP probably looks like a small, it's pretty small. It can sit on a nightstand. It does have tubing and hoses though, and a mask, different types of masks. So it can be annoying to sleep with. It can be annoying for the person's partner. So some other things that we think about is if you're a smoker, stop smoking. If you drink, consider not drinking. Consider not drinking before bed because it changes your sleep pattern, right? There are surgical options. Um, Biggest teaching related to that CPAP is making sure that people keep it clean. Again, that is a nice, moist, warm environment. So we're thinking bacterias, we're thinking yeasts, right? So all of that tubing, all the masks, all of that stuff needs to be clean on a regular basis. Complications of sleep apnea, again, heart stuff, right? It puts a strain on the heart. Those intermittent periods of hypoxia, it's hard on your heart. Your heart's like, what the heck is happening? Um, so you can get cardiac ischemia, you can have an MI, strokes, AFib, heart failure, sudden cardiac death. You know, none of that's good. And this also plays into erectile dysfunction, because if my heart's not happy, my blood flow's not happy, and for the penis to work properly, you need proper blood flow, like it or not. So it can play into erectile dysfunction. And remember, sleep apnea primarily affects males. So erectile dysfunction, that's a big talking point. So just keep that in mind with your sleep apnea people. Our assessments, same deal. Uh, Vitals, right? Hypertension and dysrhythmias, possibly, because of the hypoxic periods. Maybe some inflammatory markers like our CRP and our ESR. We're going to talk about healthy weight, activity history. We're going to talk about social history like drinking and smoking, that sort of thing. Actions, we're going to, administer meds as ordered. Maybe they're going to have to be on something for blood pressure, and there's a lot of teaching that's related to that. Diagnostics, maybe a sleep study, electrocardiogram, echo, we want to check on the heart, see how that's doing. Teaching, um, basically, let's see, just talk about risk factors and management. The weight thing is huge with sleep apnea, and that's a modifiable risk factor. So that would be a conversation to have. You're going to talk about meds if they're on hypertensives, a lot of stuff with blood pressure meds. And then we're going to talk about a CPAP if they go and use a CPAP, keeping that clean, keeping an extra mask, extra tubing. My son-in-law has to wear a CPAP, and we brought our puppy over to visit up in Flagstaff when the puppy was about 6 months old, and the puppy ate all the tubing on my son-in-law's CPAP, and they did not have extra tubing. They had to order it. So keep extra tubing and masks in the house just in case you have a puppy come over and they eat all your stuff. You never know. All right, now we're talking about laryngitis, okay? Laryngitis is the most common disorder of the larynx. Causes of acute laryngitis can be upper respiratory infection, maybe pollutants, GERD, right? We have all this acid going up the esophagus, so that can definitely lead to laryngitis. And asthma inhalers. When we use asthma inhalers, right, it's a puff of medication down that airway. It can dry it out, and so that can use or lead to laryngitis. Also, of course, vocal misuse or strain. If you go to the Taylor Swift concert and you're singing all night, coming to school the next day, maybe you've lost your voice, right? So vocal misuse or strain. Predominant symptom is hoarseness. So the big thing to remember is that laryngitis lasts 7 to 10 days. Okay, after about 7 to 10 days, that hoarseness should go away. If you have a cough, that should go away. Whatever you have related to the laryngitis should resolve in 7 to 10 days. This matters because if it doesn't resolve in 7 to 10 days, then we are thinking there's something more going on. Possibly cancer, worst case scenario, but you could also have some sort of obstruction, maybe polyps, maybe some sort of growth, something going on. So 7 to 10 days on our laryngitis, all right? Um, We may have, you're going to see signs similar to like upper respiratory infections also. So you can have a cough, postnasal drip, fatigue, maybe be a little tired. Again, and if you have postnasal drip and that snot turns yellow, then we start to think infection. You know, we always keep that in mind. Diagnosis is just made on the complaint of hoarseness. Um, and we're kind of social factors. Have you strained your voice lately? Did you go to Taylor Swift? You know, stuff like that. Risk factors. We also want to talk about risk factors for cancer in throat and lungs, simply because we want to rule that out as a possibility. Okay, so long-term smoker, maybe, you know, excessive drinker, history of GERD. Believe it or not, GERD can also lead to throat cancers. So, chew, like tobacco chew. I don't know if people really do that anymore. Nowadays, you know, you'd ask about vaping, all that stuff. So you talk about social things or two also, because it, like we said, it's likely laryngitis, but it could be something more serious. We're going to do a visual exam of the larynx, ear, nose, throat. They can do a laryngoscopy, so flexible fibroscope that goes down, takes a look around. That's possible. You know, we're looking for polyps, tumors, that sort of thing. Treatment really for laryngitis is voice rest. You know, give it a rest. Let that inflammation and swelling go down. You may use humidifiers, vaporizers just to add in some moisture to the air. Drink plenty of fluids. Avoid any irritants like smoking, even secondhand smoke. And if it's bacterial, you know, then we may be on antibiotics. Um, Assessments, all the things, right? Vitals, temp, all of that. We're going to look at edema, you know, going to check out the airway, make sure we're not worried about the airway. Assess for presence of stridor. Um, After you extubate someone, so you remove either an ET tube or, well, primarily an ET tube, but that whole area can be really irritated. People can have laryngitis after you extubate an ET tube because that plastic tube has been in there just irritating that whole area. So if we are talking about laryngitis related to extubation of an ET tube, then we are really going to want to pay attention to breath sounds like stridor that indicate that inflammation may be closing down that airway. Because then we worry about losing our airway. All right. So that is laryngitis related to, though, secondary to the extubation of an ET tube. But again, just think about it. That whole area, we've stuck a tube down your throat. It's going to be irritated. So we just want to make sure that inflammation is under control. Actions like we talked about, humidified air, meds as ordered. If our person has been extubated, you're going to have emergency equipment at the ready, right? Maybe your cart is outside of the room. Maybe you have stuff at the bedside. Just be ready for that. If your person has laryngitis and we want them to rest their voice, we need alternatives for communication. So pen and paper, whiteboard, board with pictures, like, right? Somehow letting them be able to communicate without using their voice. Teaching, you know, any teaching related to meds, voice rest, increased fluids, and then of course smoking cessation. Risk factors, we're going to move on to laryngeal cancer. Risk factors, obviously smoking and alcohol, poor dietary habits, compromised immune system. Some genetic syndromes will actually put you at increased risk for laryngeal cancer. Occupational hazards, GERD. Um, Let's see. Patients with GERD are also at risk for the esophagus. So up in that area, use of tobacco in any form can increase your risk of cancers. Head, neck, larynx, this whole area. If you've ever seen somebody with their jaw removed because related to cancer, that is alarming. That is something you never forget, let me tell you. Especially when somebody forgets to mention that in report. You're like, oh, all right. Occupational exposure, right? People who are exposed to chemicals, coal, steel dust, paint fumes, asbestos, um, laryngeal cancer is about 4 times more common in men. And even though, women are out there doing these construction jobs and that sort of thing, that's not incredibly uncommon anymore, but it is still primarily our men working these construction jobs, working these uh, jobs where they're exposed to all these fumes and chemicals and that sort of thing. So it's a lot more if you're a male working these jobs, much higher risk. Laryngeal cancer is slow growing, so more than half with laryngeal cancer are over 65 years of age, and it's also more common in Black and white populations compared to Hispanic and white and Asian populations. Sorry. So clinical manifestations, really we talk about that hoarseness that does not go away. If you have hoarseness, that does not resolve in 2 weeks. We are thinking, we're thinking bad things, right? Treatment of laryngeal cancer based on factors such as stage of the disease, location, size of the tumor. Is it a reoccurrence of a tumor? That's going to direct treatment as well. So as usual with cancers, it's radiation, possible surgery, and chemo. Same old, same old. So surgical procedures, they can go in, they can remove stuff. When we're talking about the larynx, we worry about how speech, swallowing ability, and breathing is going to be affected. So that might be conversations that you're going to need to have. Early diagnosis of laryngeal cancer has a high cure rate with a 5-year survival rate of 80 to 95%. So that's pretty good. That's pretty good. Presence of comorbidities such as diabetes, heart disease, or hypertension can affect survival. But that's really not news, right? Those comorbidities are going to affect survival regardless of what you have going on. Then, of course, we talk about smoking cessation, and that's really it. It's not too bad. This is our evidence-based practice. This is slide 15. This is related to smoking cessation. So our first line for smoking cessation is nicotine replacement therapies. Okay, so nicotine, gum, patches, lozenges, whatever. Replace the nicotine. That is our first line. We also may use non-nicotine medications such as Chantrix and bupropion. Bupropion is also Wellbutrin, so you may have talked about that in mental health. It can be used. So Chantrix and bupropion are our non-nicotine meds, and then we couple that with nicotine replacement. Second line is clonidine. So there you go. So just remember that, okay? Laryngeal cancer RN considerations, a review of risk factors. What risk factors are modifiable? Can we talk to them about stop smoking? Can we talk to them about drinking a fifth every day, right? What can we talk to them about? So review of symptoms, hoarseness, earache, sore throat. Again, we're going to evaluate all the things up in this area. With hoarseness, you want to know if they can swallow. Is there pain associated with it? And is there any obstruction going on? So with swallowing, do we worry about them aspirating? Lab assessments, WBCs, platelets, post-op, if they were to have to go into surgery, it's all the post-op things, vitals, O2, We're going to want to make sure, let's say they have to put in a trach related to this, right? Patency of the trach. Is that trach functional? Is it placed correctly? Is there excessive bleeding? Is the person in a lot of pain because they really shouldn't be? And then we also want to think about weight, nutritional intake, and calorie count. If our person is having any difficulty eating and it's obstructing that airway at all, and so maybe they're not eating because they have trouble swallowing, we may need to think about like high protein shakes and stuff for them. Especially if they are suffering from cancer, you can end up with wasting and that sort of thing. If we're giving chemo, we're going to want to do teaching about the chemo. We're going to want to talk about the side effects of chemo and radiation. Chemo can increase bleeding risk because it lowers the platelet count. So we're going to talk about bleeding precautions, right? Just be aware. Try to be a little bit extra safe. Don't cut yourself shaving. Try to avoid any dramas, right? If our person ends up with a trach, we're going to use humidified oxygen, pulmonary hygiene. You may hear that called pulmonary toilet as well. Old school pulmonologists are going to say pulmonary toilet, but it's kind of the same thing as pulmonary hygiene, where we do all the things to keep the trach safe. So it's turning, coughing, deep breathing, mobility, suctioning equipment at bedside. You're always going to have a replacement trach and a trach one size lower at the bedside. If your person ends up having a laryngectomy, they are going to have a permanent trach tube in place. So that means we need to train our person, teach our person how to go home and take care of this trach tube, because they're going to be changing out the trach. They're going to be cleaning the inner cannula probably. They're going to be looking for signs and symptoms of infection, all of that stuff. We're going to want to talk about aspiration precautions. Post-laryngectomy, the patient will not be able to speak due to the removal of the larynx. So again, back to the pen and paper or a picture board, whiteboard, anything like that. Maybe a nutritional consult because we're worried about that swallowing. Teaching, we're going to talk about any diagnostics that may be upcoming. We're going to talk about disease management, what the outcome is. If they do have to have a laryngectomy, what does that look like? What does that mean for their life? What if they work as a phone operator and they have to have a laryngectomy and now they can't talk, right? Maybe they're in phone sales of some sort. Answer phone calls all day long. Who even knows? Call center. That would drastically change their life. We're going to talk about skincare. We don't want them using heating pads. You don't want lotions, powders, anything. If somebody has a trach, you don't want powders and stuff going down the tracheostomy. Let's see, radiation therapy and chemo. We really talk about taking care of the skin. Again, no heat, no ice. It's soaps without fragrances. Mild soaps is what we call them. Mild soaps, warm water for bathing, all of that stuff because we worry about skin breakdown. Oral care, you want a soft bristled toothbrush, floss after meals and bedtimes. Basically, we want to reduce risk of infection. You can get ulcerations, you can get bleeding, that sort of thing. So we worry about open spaces and infection. The mouth and this whole area has a lot of normal flora, a lot of normal bacteria, and we don't want it to become an infectious process. Sometimes production of saliva can be reduced, so we would want to talk about dry mouth and treatment for that. Dry mouth can also lead to cavities and breakdown that way. So that would be topics of conversation. With radiation, vocal hoarseness may actually worsen. So that would be something to talk about. With nutrition, we want easy to chew foods, easy to swallow foods if everything is still intact and they can eat. But we want to reduce any risk of aspiration. Looking through here. Sorry. See what we really need to know about. All right, I think that is good. All right, laryngeal trauma. So this is rare. I really wouldn't worry too much about this, right? This, according to our book, laryngeal trauma occurs approximately in one patient per 14,000 to 42,000 emergency department visits. So that is less than 1% of blunt traumas. Um, and it talks about the fact that it's because the larynx is sort of protected, right? We have all this kind of going on around it. So it's more common in females just because women have slimmer, longer necks. But males tend to present with the highest percentage of trauma because because of their participation in body contact sports such as fighting. I also, whenever I read that, I also always think of the show Jackass, and it's like, yes, of course, males present more with this, right? So this can be blunt trauma. It can be related to assaults, crush injuries, falls, motor vehicle accidents, strangulation. That'd be a problem. It can be penetrating injuries like gunshots or stabbings. Outcomes dependent on early recognition and maintenance of adequate airway. Signs and symptoms. They just depend on the extent of the injury. So you can have hoarseness, pain, stridor, difficulty breathing, dysphagia, difficulty swallowing, right? You can have hemoptysis, which is bloody sputum. Your airway can become obstructed, which is probably our biggest concern. Diagnosis, physical inspection, we're going to look for swelling, discoloration, tracheal deviation can indicate that something is going on. And then, of course, any open wounds. They may use a CT. They can do a laryngoscopy, or a bronch. So that's like a flexible tube that can go down, take a look, see what's happening. The priority of care in patients with laryngeal trauma is to ensure and maintain a patent airway. Obviously, ABCs all day long. Maintenance of the airway may include endotracheal intubation or tracheostomy. Because of the potential of cervical spine injury related to laryngeal trauma, you're probably going to want to stabilize that cervical spine as well. And then as diagnostics go along, hopefully rule out any cervical trauma. This is a safety alert from our book. Patients who have experienced neck trauma are at high risk for airway occlusion and obstruction. Have an emergency tracheostomy insertion set at the bedside, and closely observe the patient for changes in respiratory rate, respiratory effort, and the development of adventitious breath sounds, especially stridor. So our assessments, vitals, right? Vitals and respiratory stuff. Physical assessment, we're going to look at the neck and upper airway. We're going to identify risk for laryngeal trauma if we note any discoloration, change in voice, stridor, what maybe accessory muscles for breathing. Restlessness often indicates hypoxia in your person. So if our person is notably restless, we may want to think hypoxia. Um, you're going to have your emergency equipment at bedside. We're going to provide humidified air via a face mask or face tent. Um, if we have trauma, we're likely not going to be able to use a nasal cannula because we want to make sure that our oxygen and humidified air is bypassing any of that trauma. So nasal cannula would not be the best option for this. We also want to keep the head of bed elevated at 45 to 30 degrees. That just helps with respirations, with breathing. Aspiration precautions. I'm going to make my person NPO. Teaching, we're going to talk about all those signs and symptoms. We're also going to teach them when to be worried. when to contact and seek emergency medical care. So that would be the sounds like stridor, increased work of breathing, that accessory muscle use, all of that. We're going to maintain voice rest simply because we don't want swelling and irritation to get in the way of anything. We want to reduce all that swelling and trauma. So we don't really want our person to talk. We are just going to closely monitor their ability to breathe. And that's pretty much it with that, because again, ABCs is our biggest concern. All right, lower respiratory disorders. We are going to start with asthma here. So asthma is an inflammation problem, right? So about 18 million Americans suffer from asthma. This includes 6 million children. 8% of children and 8% of adults have asthma. That's, that's a pretty decent chunk of the population. More common in females than males. Children, asthma is more common in boys than girls. Uh, let's see. Patho. So asthma, chronic lung disease characterized by intermittent reversible airway obstruction resulting from inflammation of the lungs' airways and tightening of the muscles that surround the airways. So basically, just remember that airway is an inflammation disease of the airways, not the alveoli. Alveoli, that's reserved for our COPDers. Okay, this is just all the little bronchioles, the bronchioles, the airways, everything inflames. We worry about it closing off. All right, so airway obstruction and bronchial hyperresponsiveness. So the bronchioles respond over the top, right? There's no reason for them to get so inflamed and closed down. That's not helpful. I could die, right? So it's hyper responsiveness. Risk factors, really, we think a lot of times asthma is triggered by exposure to irritants. This can be perfumes, it can be smells, it can be, we talk about working related to environmental irritants, absolutely. Smoke, think about all those people over in California, all that smoke in the air. And then, of course, you've got exercise, cold weather. Um, we talk about cigarette smoke, back to smoke, cigarette smoke, mold, pollen, dust, animal dander, viral infections, allergic rhinitis. You can have an allergic rhinitis situation going on, and it can exacerbate your asthma. Also, food and medication allergies, and then emotional stress. The one thing we learn about between autoimmune is how much emotional stress can play into inflammation processes. So they're not to the point of calling asthma autoimmune yet, but emotional stress plays into it. Okay, so it's just exposures to whatever these triggers are, and people do have different triggers. You can have multiple triggers and different triggers, but exposure to the trigger then produces that inflammatory response. When we think about asthma for breath sounds, we think wheezing, all right? Wheezing is our breath sound associated with asthma. You can also be short of breath, you can cough, you can have increased sputum, increased respiratory rate. When we're talking breath sounds and wheezing, one of the things that can happen is maybe all of a sudden we don't hear wheezing. That is a red flag. That means that those little airways have inflamed to the point that there is nothing going in or out. And obviously that is a problem. All right. So with asthma, quiet lung sounds should raise concerns. The person can also experience chest tightness, tachycardia. This can be related to oxygenation, oops, sorry about that. Oxygenation, lack of oxygenation, really, hypoxia, right? It can be related to anxiety or a side effect of treatment. You know, bronchodilators are one of our go-to treatments, and they can result in tachycardia. So a classic sign of an asthma attack is the inability to speak in full sentences. Okay? Inability to speak in full sentences. That tells us our person is having problems breathing. Diagnosis and assessment, we want a detailed patient history. We're going to do a focused physical exam. We may do pulmonary function tests, x-rays, pulse ox, ABGs. Patient history, including illnesses, family history of allergies or asthma. Eczema. Eczema is related to asthma. They are not exactly sure why, but this is factual information. So a lot of times kids will have eczema and then end up with being diagnosed with asthma. So history of eczema can indicate that this is an asthma related situation. We're going to talk smoking history, occupational history, exposure to environmental triggers, all of those things. We're going to talk about when they notice exacerbations. Is it in the evening? Is it during the day? Is it related to a certain time of the year? You know, like when things are blooming, right? And then we want to know what they do to relieve symptoms, okay? A lot of people have certain things that they use to relieve symptoms. Maybe they just rest. Maybe they sit in a steamy shower and then go out in the cold. A lot of times the shock of it can open airways. So we want to know what they do. Pulmonary function tests are used a lot to evaluate asthma. So pulmonary function tests are a group of tests used to evaluate the functioning of the respiratory system. Some of the more commonly PFTs are spirometry, peak expiratory volume, and pulse ox, right? So those tell us what is up with the respiratory system. There are other PFTs available for use in confirming a diagnosis of asthma when routinely used tests or exams do not provide a clear diagnosis. Once asthma is diagnosed, the disease is classified based on frequency and severity of the symptoms. So one classification through the Global Initiative for Asthma Guidelines is based on the level of control and the treatment recommended. So asthma is classified as mild, moderate, or severe. And you can have uncontrolled, okay? You can have uncontrolled asthma. Asthma severity may be assessed retrospectively through close evaluation of the treatment required to manage symptoms. Complications. So one of the complications related to asthma is the status asthmaticus. This is an acute exacerbation of asthma when the asthma is not responding to any treatment. This is life-threatening because if we don't get that inflammation under control, our person is not going to be able to breathe. So your person might end up being intubated, all right, with status asthmaticus. This is our safety alert. This is talking about the absent or diminished breath sounds. We really worry about the obstruction level related to those airways. Also, we worry about increasing CO2 levels, all right? Increasing CO2 levels can indicate impending respiratory failure because, again, we don't run on CO2, we run on O2. And if we have too much CO2 buildup, our O2 can't even get in and sit on the little markers where we can utilize it, all right? Any of these airway diseases is a problem with getting CO2 out, not getting O2 in, all right? So we can gasp and try to breathe all we want, but if we are not expelling that CO2, then gasping and supplemental oxygen not going to be beneficial. Okay, so just remember that these respiratory diseases are a problem with getting CO2 out. This one talks about some pulmonary function tests. Spirometry is a test that measures airflow and lung volumes, such as forced expiratory volume. So one of the major tests that we use is FEV in 1 second. So it's like FEV1. So that measures how much air we can force out of the lungs after a full inspiration in 1 second. So I breathe in, and then I'm going to blow out as hard as I can in 1 second. So, right? That's going to see, is my expiration diminished? And again, that's a problem, because if my expiration is diminished, I'm going to have a problem getting CO2 out, right? That is my problem. So a decrease in volume by 15 to 20% below the predicted value for your age and gender ends up with a diagnosis of asthma. Okay, so that's how they use that. Peak expiratory flow readings measure maximum airflow expired during a forced expiration. This one we use multiple readings. We compare it to when a person is not having an exacerbation and compare it to when they are having an exacerbation. An asthma person should be using a peak expiratory flow meter at home, tracking their readings so that we can kind of see what's going on with them. Also, we're going to use our pulse ox. What is our percentage of O2 relative to the total hemoglobin, right? That's what our pulse ox is telling us. Oxygen saturation. We're going to use ABGs. That's going to give us a view into our acid-base balance. Are we acidotic? Are we holding on to too much CO2? What's going on with that? So let's see. So this just talks about, although ABGs provide the best information with regard to evaluating the patient's overall condition and identifying responses to oxygen, ventilation, and medication therapy, the SpO2, so our pulse ox, provides an accurate indicator of oxygenation. So we can trust our SpO2. We can trust that pulse ox to be telling us where that person's O2 is at. This talks about the steps of using a peak flow meter. This is slide 24. If you are not familiar with the steps of using a peak flow meter, please take a look at this slide, all right? Asthma treatment. So we're going to develop an asthma action plan for our person. Everybody has different triggers, and therefore everybody's going to need different types of treatment, right? It's kind of like pain. Pain is dependent on the person. So our asthma action plan, because asthma is very individual, we're going to have an asthma action plan for all of our people. So this is going to talk about how to manage the asthma, peak expiratory flow readings, meds, awareness of worsening symptoms, acknowledgement of triggers, when to seek emergency care. We're going to have our pharmacological treatment on there. What has worked in the past. And then we do recommend seeing a pulmonologist. They're going to specialize in this. When a person is first diagnosed, they're probably going to be seeing their pulmonologist pretty frequently. And then as it goes on and the asthma becomes more controlled, they're not going to have to visit their physician as often. But we're going to use anti-inflammatories, bronchodilators, anticholinergics, leukotriene modifiers. Keep in mind with asthma, we have long-term control meds and then rescue meds. Our rescue med is our asthma inhaler that we carry on us at all times. It's a bronchodilator. Longer-term meds can also be bronchodilators. People can be on steroids. You have inhalers, long-term inhalers these days that couple a steroid with a bronchodilator. Those can be used for asthma and COPD. but we talk about rescue meds versus control meds. All right. So, and again, that rescue med is our short acting bronchodilator. All right. That is the gold standard. So, let's see. Oral anti-inflammatories, prednisone, solumedrol, those may be used to help with acute exacerbations. You know, our steroids take down our inflammation, so that's going to help with that whole process. Most of the times people are not on long-term steroids, but it is possible. It is possible that they may be on like a low dose, just long-term steroid. Um, you can also, like we talked about, be on an inhaled corticosteroid. Don't forget, if your person is on an inhaled corticosteroid, you worry about thrush in the mouth, which is a yeast buildup, okay? That's opportunistic. It's because the steroids kill off good things in the mouth, and thrush is able to proliferate. Bronchodilators. Bronchodilators relax the bronchial smooth muscle, all right? Bronchial dilators, beta-2 adrenergic agonists relax the bronchial smooth muscles. So our airways open and that decreases the obstruction. Anticholinergics are another bronchodilator. Um, they relax the bronchioles, which are those little small airways. All right. Um, Anticholinergics, I'm lying. I'm taking that back. Anticholinergics, sorry. Anticholinergics relax the muscles around the larger airways and bronchi. Okay? I'm lying. Anticholinergics relax muscles around larger airways and bronchi. It's our beta 2s that do the bronchioles and small airways. Sorry about that. Beta 2s, bronchioli, small airways. Anticholinergics, muscles around larger airways and bronchi. Okay? All right. Leukotriene receptor antagonist, just another type of med. And then of course steroids, which we've talked about. This is just a cutout from your book, all right? So this talks about what your meds do. So you definitely want to be familiar with what, like they work on smooth muscle. You know, albuterol is a beta-2 adrenergic agonist, okay? It's short acting. So that's our rescue inhaler. Our anticholinergics. This is Atrovent, all right? And then we have the combined, which is the beta-2 short acting combined with an anticholinergic. So you want to take a look at these. Inhaled corticosteroids versus systemic corticosteroids. Asthma nursing considerations. So vitals. Remember that a lot of these medications are going to increase our heart rate, right? So tachycardia. So we want to be able to educate people about that this is an expected sign. We're going to, when we're talking vitals, we're going to throw in their peak flow measurement. You know, what's going on with that? And then our pulse ox, where are we oxygenating appropriately or not? Goal is to maintain SpO2 or pulse ox at 90 or above, and monitor for signs and symptoms of hypoxemia, which is restlessness, anxiety, increased blood pressure, and pulse rate. We're going to look at our ABGs. We want to see if we are in an acidotic state, a respiratory acidotic state, due to holding on to too much CO2. We are, of course, going to listen to breath sounds. Don't forget, wheezing is what we think about. And then absent or diminished breath sounds can mean we have an obstruction. We're going to monitor for level of consciousness. Hypoxemia can result in changes to level of consciousness because the brain is not getting enough O2. Don't forget about that ability to speak in full sentences. When our person is having an asthma attack, It is a classic sign to have an inability to speak in full sentences. That indicates respiratory distress. If our person has a cough can work to further irritate the airways. So we would want to try to do what we can to help with the cough. Use of accessory muscles. Don't forget, use of accessory muscles are bad because the body's going to get tired, and then we increase our risk of respiratory arrest. We're going to look at positioning. Tripod, we mostly associate tripod with COPD, but tripod position can work for asthma as well. But classically, we associate that with COPD. We also want to make sure our person is sitting up, like a nice semi-Fowler's or high Fowler's. If you're ever having to choose between putting your respiratory patient in high Fowler's versus semi Fowler's, in regard to testing questions, go with the high Fowler's. The higher and straighter we can sit our patient up, the better the lungs are going to be stretched out and open up. So in theory, the better our person should be able to breathe. Okay. Tripod positioning just helps decrease work of breathing. So if they're struggling, if they're tired, if they have that work of breathing, they may assume that tripod position. But again, I want you to associate tripod with COPD. Let's see. We also, one of the other things that we throw into as nurses when we are assessing our asthma patients is whether or not they've been previously intubated. The reason we care about that is because our person could reach that level of severity again. Like that's a huge bad asthma attack if you have had to be intubated. So we want to know that about their history because we don't want to risk them getting to that severity again. We want to know about that beforehand. We're going to put our person on O2 to maintain that O2 at 90%. We're going to give bronchodilators, right? They work on the smooth muscle. We're going to give anti-inflammatories, anticholinergics. Those work on the smooth muscle around the larger airways. Teaching, again with our action plan, right? Avoidance of risk factors, pursed lip breathing. All right, so pursed lip breathing. Remember, our problem is getting CO2 out. So my pursed lip breathing, I'm going to inhale for 2, exhale for 4. I'm exhaling double the time of my inhalation because I'm hoping to get out more CO2 because that's my problem, all right? Inhale 2, exhale 4. We're going to do med education. I don't want my person stopping their oral steroids out of nowhere. That you can cause a crisis, right? You don't stop your steroids out of nowhere. We taper steroids. I want my person doing their peak flow meter. I want them to stop smoking. I want to know that they are using their inhaler correctly. And any of this equipment that they have, peak flow meters, NEBs, meter dose inhalers, aero chambers. Aero chambers are what we put on the end of a meter dose inhaler to kind of help with breathing in and controlling that breath. But all of this stuff needs to be cleaned, okay? We don't want buildup of stuff. This is a visual analog dyspnea scale. So this allows our patient to give us a subjective reading on where their shortness of breath is. So 0 is no shortness of breath all the way up to 10. So this could be, even though this is subjective, this could be another thing that we put in their asthma care plan. After you exercise, where is your shortness of breath? Or during exercise, where's your shortness of breath, right? If you do not know what an aero chamber is, this is slide 31. this talks about the proper use of an aero chamber. So the aero chamber is used, it helps control breathing. So you put the med, you squeeze the meter dose inhaler into the aero chamber. The aero chamber is what actually goes into your mouth and you breathe through the aero chamber. Some aero chambers, if you breathe too quickly, cause a whistling noise. So that is so it helps control your breath. Because if I'm taking a bronchodilator, I want to make sure I'm taking a nice deep breath and getting all that medication down into my lungs where I want it, where it's going to do the most good. So the aero chamber just kind of helps control that breathing process, getting that med down to where it goes, where it needs to be. So if you're not familiar with an aero chamber, go ahead and take a look at this. When we take our deep breath in, then we want to hold our breath for about 10 seconds. And again, that's helping keep that med down in the lungs where it needs to be. Meter dose inhaler. Just in case you miss the video in class, there is a video on meter dose inhaler use in ATI. Definitely watch that. Meter dose inhaler, I don't know if any of you have asthma, but I've had asthma my whole life. And my teaching has always been, even if you don't have an aero chamber, you put the meter dose inhaler in your mouth, you click it, you breathe in, you hold for 10 seconds, life goes on, right? The teaching in the ATI video is you actually hold that meter dose inhaler 1 to 2 inches away from your mouth and do it and breathe in. So I will be honest with you, we tried to look up where this teaching came from. It seems like both teachings are still available out there, but ATI is telling us to hold that meter dose inhaler 1 to 2 inches away from your mouth. So I want you to make sure to go in and watch that video, all right? We'll watch it in class, but on the off chance you miss class or whatever, make sure you're aware of that because that's weird, right? Totally weird. All right, moving on to COPD. So COPD is emphysema and chronic bronchitis. Both are characterized by airflow limitations. The airflow limitation is progressive. It's associated with abnormal inflammatory response of the lung to noxious particles and gases. Both diseases and COPD cause obstruction to the airflow, but they kind of have different mechanisms, right? So emphysema is caused by the destruction of the alveoli. So these poor little alveoli, they are our little inflatable grapes down in the lungs at the bottom of the bronchioles, right? They are responsible, they're like a water balloon. They are responsible for the gas exchange. They're elastic, they inflate, deflate, pump the CO2 out, inflate with the O2, change it into CO2, that whole thing, right? So what happens with the alveoli when we are talking about emphysema is the alveoli, because there's so much CO2 being held onto, the alveoli become hyperinflated. So our little grapes become these big water balloons and they lose elasticity. So the problem is with alveoli, their whole thing is gas exchange by inflation and deflation. So if they lose elasticity, they no longer deflate appropriately and they're hyperinflated. So they never are able to fully push out what they are exchanging. So they're never able to fully push out all that CO2. So people with emphysema end up holding on to too much CO2. All right. Now, chronic bronchitis, it's similar to asthma because it's an inflammation process. So you end up with inflammation of the bronchioles. Chronic bronchitis, you kind of end up with this cough and this heavy sputum production. I don't know if you've ever gone out to eat and you've seen a person, heard a person, older person usually, Sometimes they'll be on O2, and they just have kind of this hacky cough, and you can hear the sputum rattling around. That is your chronic bronchitis, people. All right. It's just this hacky cough. Um, let's see. Getting down here. Let's find out what I haven't told you about yet. Let's see. Tobacco smoking, 10,000% primary cause of COPD. Okay. Approximately 85 to 90% of deaths are caused by smoking. It's always shocking to me how many people have COPD, are on oxygen, all the things, and do not stop smoking. I don't know if the thought process is, well, I already have COPD, who cares? But COPDers, a lot of them do continue to smoke. Other factors, but are much less risk factors, are like preventable workplace exposures. This can be vapors and gases and that sort of thing, but also think about exposure to secondhand smoke. Secondhand smoke is a big factor related to these respiratory diseases. Let's see. You can also have COPD related to deficiency of an enzyme called alpha-1 antitrypsin, but this is like less than 1% of COPD people. So, you can stick that way, way, way back in your brain. We always think of COPD as related to the chronic bronchitis or the loss of elasticity in the alveoli. Okay. So clinical manifestations, use of accessory muscles when breathing, shortness of breath, that tripod position. Our emphysema person is going to have that barrel chest. Emphysema is the one where the alveoli lose elasticity. So that person is going to have the barrel chest look. It's going to be a transverse diameter, transverse side view, 2 to 2 rather than 1 to 2. Okay. Patients with emphysema, we call them pink puffers because they're going to have kind of a reddish complexion a lot of times, and they're almost like when they breathe, it's like puffing. It's like you can hear it, right? And they end up with this kind of reddish pink, I don't know, look to their faces. Chronic bronchitis. So the bronchitis is the inflammation of the bronchioles. These people, here we go, people, we call blue bloaters. They have, they're the ones with the excessive mucus, the productive cough. So they get kind of a bluish tone because of cyanosis, right? They're not getting enough O2. They end up with this kind of bluish tone to them. One of the biggest things we worry about related to the chronic bronchitis is right ventricular enlargement, which is called cor pulmonale. So this is right ventricular enlargement of the heart. So this can end up leading to right-sided heart disease. All right. Risk factor, again, risk factor, just remember, smoking, hands down. This picture, slide 33, it shows what lungs with chronic bronchitis look like, right? Those bronchioles, just, they're inflamed, they're small, they're too little to exchange air. And then with the emphysema, it shows what our little alveoli are doing, how they lose elasticity. Diagnosis of COPD based on patient history, physical assessment, spirometry, may do a chest x-ray just to rule out any other causes for respiratory distress. They may do a CT if we want to see those lungs in more detail. They're going to do the pulmonary function test. The FEV1, FEV1 is where I inhale and blow out in 1 second, and they measure how much I blow out. There's norms, and they're going to compare your reading with the norms. COPD is a progressive disease, okay? It's not getting better, it's only getting worse. So part of the problem, this is a lifelong thing. Once you have been diagnosed, it's lifelong. We can do the meds, we can try to preserve function, but it is a progressive disease. Management plan for COPD has 4 goals. So we want to assess and monitor disease. We want to reduce modifiable risk factors. We're going to manage the COPD and manage exacerbations. The better we get at managing exacerbations, the better off that person's going to be, because they're going to be able to stay at home. Maybe they're on O2, but they're at home. They can go about their daily lives, rather than ending up in the hospital. We want to do regular pulmonary function tests, and check chest X-rays. Just see what's going on, right? Because there can be structural changes to the lungs. So if our person is having an exacerbation, we're also going to look at an ABG, because that's going to tell us where our CO2 is sitting. We expect these people to be acidotic. We expect them to be, because they are holding on to CO2. So we expect that CO2 to be out of range. But there comes into question, how out of range are they, right? And then, of course, we worry if they're way out of range. We worry about all the things related to holding on to CO2. Sputum cultures assessed to identify organisms causing infections, maybe, right? Imagine if you end up with pneumonia and you've already got this COPD process going on. We're going to want to talk about them, about smoking cessation, obviously, right? And then any other triggers that they may identify. Excuse me. Let's see. One of the complications, you can end up with a spontaneous pneumothorax. This can cause so we have our alveoli, right? They are hyperinflated. We talked about barotrauma. Remember that when we were talking about like COVID and that sort of thing? When we talked about vents, and you can have, if the PEEP is too high, your alveoli became hyperinflated and can rupture. So this is the same thing. So with emphysema, our alveoli can become so hyperinflated because of that loss of elasticity that they actually rupture. So you end up with this air being burst into the lungs. So you can end up with a spontaneous pneumo. Really, we start thinking pneumo when our person has an increase of shortness of breath. When all of a sudden they're like, whoo, I cannot breathe. And maybe they couldn't even breathe before, but all of a sudden they're like, whoo, that just feels weird. And we treat a pneumo with chest tubes, okay? Put a chest tube in, get that air out of there, and that allows for re-expansion of the affected lung. All right, so for our assessments, for our RN considerations, obviously we're going to look at O2, right? Now, keep in mind, our goal with O2 is always to keep it above 90. Sometimes that's not possible with our COPDers. They may hang out at 87, and that is just kind of knowing, what is normal for them, okay? Because that goal of 90 may not be possible. And we do not want to hyperoxygenate our COPDers, because it can end up with oxygen toxicity. We had talked about that earlier, right? If we throw too much oxygen at these people, the current thinking is that they use a hypoxic drive to breathe, for the brain to tell them when to take a breath. And the hypoxic drive is driven by the buildup of CO2. All right. So if we go and throw a bunch of O2 at this person, the lungs aren't necessarily going to be able to use it because we have CO2 sitting on those little markers there. We can't exchange O2 if our CO2 is taking up the space. But what happens is you end up with an overdilution of oxygen in the blood, and that goes to the brain, and the brain goes, oh, I have plenty of oxygen, I'm fine, right? And so the brain then thinks it's not in a hypoxic state anymore. And so it can shut off the drive to breathe, which is super crazy. That thinking is being a little bit challenged right now. There's some interesting articles out there about that, but currently that is our thought related to what is going on with COPD and that hypoxic drive, okay? And that is why we do not want to over oxygenate our people. So if your person says my normal O2 is 87, that's where I live, we do not want to try to get to 90, right? Because that could be detrimental to them. So back to RN considerations with assessments, obviously respiratory rate, breath sounds. If we hear crackles, crackles can indicate fluid in the alveoli. We worry about that because that can be a risk for pneumonia. Also, we're going to want to teach our person how to do pursed lip breathing if they don't already know how. Our person's likely going to have a cough. And remember that a cough can be aggravating, right? It can further cause inflammation and irritation. Temperature would be bad because that indicates infection. Weight, a lot of these people, especially our pink puffers, can be underweight because when I'm chewing, I can't breathe. So they pick breathing over eating, right? So a lot of times these people will be underweight. So we need to talk to them about like protein drinks, like Ensure, that sort of thing, because that's a quick and easy way to get that weight up and keep those calories there. Actions, administer bronchodilators as ordered. These guys too could be on steroids. We may do nebulizers, anticholinergics, again with the O2. We're going to position in semi or high Fowlers if we have a choice. They may opt for tripod positioning. When we talk nutrition, think small frequent meals. Because they're able to take in more food, consume less energy. And we don't want them eating big meals because big meals are going to put pressure on the diaphragm, which makes it harder to breathe, right? After Thanksgiving dinner, everybody's sitting around the table like, ugh, right? And you just have that bloated pressure feeling. We want our respiratory people to avoid that because it's going to make it harder to breathe. So teaching, like we talked about, pursed lip breathing, huff coughing. So you take a breath, you hold it for 3 seconds, and then exhale, okay? That helps to move around some sputum, okay? Move around the sputum, get it out of there, keep it moving. We want to talk about pacing of activities. Don't overdo yourself and cause an exacerbation. Smoking cessation, nutritional needs, anything related to meds. And then we want to talk to them about vaccines. There's a pneumococcal vaccine now. So we want to talk to them about making sure that they get that. Let's see, what other vaccines? COVID, flu, anything that can reduce their risk of a pneumonia is going to be super helpful. Coping strategies, because stress can aggravate breathing difficulties. So coping strategies. And also, maybe you've got a tote around O2. What options are out there? People don't have to use a giant tank anymore. There's little, almost like pursed sized oxygen things that you can get. Does your insurance cover that? How do you get a hold of one? What do you do? How long should tubing be? Remember we talked about fire safety related to this for home O2 use. Those are all big conversations that we need to have. Also, people may be resistant to wearing their O2 if they're out and about. So you need to talk about what are the ramifications of not wearing your O2. What can that look like if you end up with an exacerbation because you caused your O2 to drop into the 60s? You know, what does that look like? So we do teaching about how to use all the stuff, but also what happens if you don't use the stuff, right? Because that can end up being a bigger problem. This is slide 36. This is box 26.4 in the book. It talks about pursed lip breathing. If you are not familiar with pursed lip breathing, please take a look at this. This is a safety alert related to our COPDers. If the patient with COPD is experiencing an exacerbation on oxygen therapy, SpO2 and respiratory rate must be monitored continuously until the condition is stabilized. If the patient is receiving too much oxygen, it may blunt the respiratory drive. The respiratory effort in a patient with COPD is triggered by the decrease in oxygen, not an increase in CO2, which is different from the patient with healthy lungs or other lung conditions. Therefore, too much oxygen and high O2 may prevent the brain from sensing the need to compensate, causing a decrease in respiratory effort. All right, our last one here is cystic fibrosis. So cystic fibrosis is a chronic inherited disease, all right? It is related to a gene mutation. So usually diagnosed in children, about 40,000 children and adults in the US have cystic fibrosis. There's about 1,000 new cases annually, so not particularly prevalent. Most patients, this talks about a high percentage, 70% of patients with CF are diagnosed by their second year of life. Survival rate for this used to be a death sentence, right? Kids used to maybe live into their teenage years, maybe. It was horrible. But now because of meds and early diagnosis, and just understanding what's going on with the disease, it's much more likely to live over 18 years of age. Our book says it's 50% of people live over the age of 18. I've actually seen where it's more like 65 to 70%. But anyway, the life expectancy is much better. Predicted median age right now is 47. So it's not like dying when you were a kid anymore. But because we have more adults with CF, you know, we're getting more complications because people are living longer with this disease, and it's a progressive disease, and we're not going to cure it. We're just going to manage symptoms. So the problem is you end up with other organs being affected. This cystic fibrosis is not a respiratory disease, it's an exocrine disease. So, and remember, our exocrines secrete hormones into the ducts. And so that's your sweat, salivary, pancreatic glands. When I was in school, we actually used to talk about a lot of times CF was diagnosed because parents would go give their kid a kiss and the kid would taste super salty, right? And that's because with CF, you end up releasing this salty sweat. Well, nowadays, starting in 2010, now we screen babies on birth in the US. So now you are more likely to get diagnosed right off the bat, which means treatment can start right off the bat, which makes your life expectancy and your prognosis a lot easier. All right. So cystic fibrosis is related to the CFTR gene. It needs to be carried by both parents. what cystic fibrosis does, well, one of the things it does is you end up producing this thick, like thick, crazy mucus. And when I say thick mucus, think of like that slime a couple years back that like kids were making with like the cornstarch and all of that. It's just thick, thick, thick mucus. So we've talked about thick mucus in relation to the respiratory system, and of course we think about aspiration and blocking airways and that sort of thing. But the problem with CF is it gets into the GI and reproductive systems. So this viscous, thick mucus clogs all of our tubes, right? It gets in there. One of the things that it does in particular is it can obstruct the pancreas. It can obstruct the liver, salivary glands, even the testes. Um, and we worry about the GI system because when it obstructs the pancreas, it leads to exocrine insufficiency because those pancreatic enzymes that work in the breakdown and absorption of food, we no longer get the benefits of those pancreatic enzymes. So a lot of times these people suffer from malnutrition related to malabsorption because those pancreatic enzymes are no longer breaking down the food and helping us absorb the nutrients that we need. So when you think about cystic fibrosis, definitely think about how it affects the respiratory system, but equally keep in mind that this nasty mucus is infecting all the other pathways in the body. And it can lead to pancreatic endocrine insufficiency. So what we do is also with the pancreas, we think about insulin, right? So that pancreatic insufficiency can lead to cystic fibrosis related diabetes as well. So all of these crazy things. So in treatment for cystic fibrosis, we end up giving pancreatic enzymes. You take them, they're a pill, you take them, and then hopefully that helps pick up where normal pancreatic enzymes, because they're not being excreted, helps with that GI functioning and stuff. The other thing with this thick mucus, you can have bowel obstructions, right? Because this mucus gets in there and it just plugs up the tubes. So you can end up with bowel obstructions. We talked about it with respiratory, what thick mucus can do. With the GI stuff, we end up with this, it's called steatorrhea, but it's this foul smelling, greasy stool, steatorrhea. And that's because we're not having the breakdown of the foods and nutrients that we need. You can get poor weight gain and growth, intestinal blockages. You can end up with severe constipation because of all this thick mucus. So it can be very debilitating. We diagnose CFTR by identifying the gene mutation, right? It causes the sweat glands to increase levels of chloride. And so these people end up with super, super salty sweat. And like I said, that's a lot of times when I was in school, that's how we learned that CF a lot of times would end up being diagnosed because the parents would be like, why are you so salty? But now in 2010, newborns are screened automatically. Treatment. So we're going to use a lot of the same meds that we use with respiratory stuff, like our bronchodilators. Mucomist. We talked about mucomist. It's a mucolytic. So that helps break down this thick, thick mucus. Anti-inflammatories, that's going to help with diminishing the inflammatory response. If I've got all this thick mucus, secondary bacterial infections are going to be a thing, right? So antibiotics if needed. You may use inhaled tobramycin, all right? Now, there are some warnings related to inhaled tobramycin. You don't want pregnant people around it for once. Stupid dog. Another one is azithromycin. as an antibiotic that we may use. We may use fat soluble vitamins. That's your ADEK, A, D, E, and K. Um, with if somebody's on long-term antibiotic use, because we want to try to get our normal flora back to normal flora if possible. We're going to use pancreatic enzymes. Um, we're going to want to watch. We're going to monitor weight and energy levels. If somebody is malnourished, they may not have a whole lot of energy. One of the things that is new in the treatment is these CFTR modulators, cystic fibrosis modulators, CFTR modulators, okay? They are specific to cystic fibrosis because they target the gene mutation. So they don't correct the gene mutation, but they try to correct the malfunctioning protein. All right. So CFTR, that CF stands for cystic fibrosis, and it's a CFTR modulator. Um, Surgical management may be a thing because they may need a lung or pancreas transplant. Both may be considered, actually. Now, the thing to know, though, is that even if they are lucky enough to get these transplants, this is a gene mutation, so it is not going to cure the disease. It's just going to buy them more time, that's kind of sad, right? But until we come up with something that can literally modify the gene mutation, this is just a chronic progressive disease. So it's a little bit sad. Our nursing considerations, mucus plugging. All right. Mucus plugging is where that mucus gets stuck. You can see mucus plugging with trach patients as well. So suctioning is huge. Use of mucolytics, things that bring down the viscosity of that mucus, makes it thinner. Temperature, because we're worried about infection. Respiratory rate, because these people are working to breathe possibly. What do their breath sound like? If we have crackles, do we have fluid in the alveoli? Are they wheezing? Do we have narrowing of airways? Weight loss, because they're choosing breathing over eating. We're going to do sputum cultures and sensitivities. We're going to do, we talked about chest physiotherapy. Chest physiotherapy is huge related to cystic fibrosis because we have this thick, nasty sputum. We need to keep all that moving. So you use pounding, chest physiotherapy, to keep that mucus from sticking to the lungs, and we want it to move about, right? We're going to use bronchodilators, antibiotics as needed, mucolytics, those CFTR modulators, pancreatic enzymes, nutritional supplements. Teaching is going to be airway clearance techniques. We want to make sure that they don't aspirate or that they don't choke on their own mucus, right? That they're able to move that mucus. We want to talk about signs and symptoms of progressing disease, and then genetic screening. Since it takes a parent, the mutation needs to be present in both parents. You want to talk about genetic screening because they run the risk of passing this along to their children. So counseling should be offered to all couples who are planning to become pregnant. We want to throw this out there as something you may want to think about. Lung cancer is our last one. I thought it was CF, but lung cancer. All right. American Cancer Society estimates for 2022, lung cancer remains the second most common cancer in both men and women. It's the #1 cancer killer in the US for both men and women. It's very prevalent in people over 65. 90% of lung cancers are related to smoking. So there we go, right? Um, Increase in risk for increase, list, holy cow, risk for developing lung cancer increases as the number of cigarettes smoked and length of time smoking increases. So the more you smoke, the longer you smoke, the higher your risk, which makes sense. Don't forget to think about the risk of secondhand smoke, occupational pollutants, in particular radon and asbestos. All right. Um, let's see. This just talks about carcinogens. Um, the carcinogens are what lead to the type of lung cancer. There are different types of lung cancer. Non-small cell cancer represents 85% of lung cancer. There's 3 different types of cells. So you can have squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Pretty good 5-year survival rate on all of those. Small cell cancers, those are bad, right? Those are our bad ones. So that's about a 5 to 10% survival rate for 5 years. So that's kind of a bleak outcome right there. So our symptoms are a new cough that doesn't go away, or a change in a chronic cough. So like if you have COPD, we kind of expect you to have a cough, but maybe something changes about it. You may have hemoptysis, which is bloody sputum, shortness of breath, wheezing, hoarseness, and chest pain. Headache and bone pain may also be present, and then potentially weight loss. So diagnoses. So, chest x-ray, CT, sputum, bronchoscopy, PET scans, maybe bone scans, abdominal scans. Um, Treatment, it's a cancer. So it's dependent upon the type, size, and location and stage of the tumor. Our non-surgical treatments, right? Radiation and chemo, same old, same old. There may be pain management related to this. So, pain control is something we're going to want to throw in. Um, you want to stop, when we talk about pain management, we've talked about pain management before already, but of course we want to try our like acetamin or NSAIDs first. That's our first step, mild to moderate pain. Step 2 is for our definite moderate. That's like our, maybe 5 to 7 on the pain scale, and we may go with opioids related to that. Step 3 is stronger, so pain maybe 8 to 10. So stronger opioids like morphine or fentanyl. They make fentanyl patches. There's lollipops, right, that you can use, all sorts of stuff related to that. And pain meds related to cancer need to be administered around the clock. So they need to be scheduled because we want to avoid peaks and valleys related to pain. Because remember, it's way easier to keep somebody at a 5 than it is to back them off from an 8. So we want to avoid those peaks and valleys. So pain meds are going to be scheduled, they're going to be around the clock. We also may need to talk palliative care with our people, right? What does the rest of their life look like? What do they want that rest of their life to look like? So how to deal with that. And then of course there may be surgeries, right? We may go in, they can actually remove an entire lobe of the lung, believe it or not. Pneumonectomy is actually a removal of the entire lung. Okay, so that's got to come with some things though. A wedge resection is when you take part of a lobe. Um, Sometimes they'll use chemo like prior to a surgery, hoping to get a tumor to be smaller, to shrink. Chemo and adjuvant therapy may be used on any remaining cancer cells. If they do surgery and maybe are unsure if they get everything or just double want to check. So all of our teaching would be related to radiation, chemo, pre and post surgical stuff. And then if they do remove part of your lung, what does that look like? Are you on O2? Are there triggers you need to avoid, like allergies, staying up on vaccines, all of that stuff. So our assessments, same old, same old. O2, temperature, breath sounds, cough. We're gonna ask about pain. We're gonna talk about appetite and weight loss. Um, if it is post-surgical, we're going to talk about what that suture looks like. Watch for signs of infection. Maybe they have a chest tube. What does that drainage look like? If you are managing chest tubes, that is above our pay grade right now. That is an ICU situation. If you are curious, that's chapter 27, but that is above our pay grade. Actions, we're going to make sure they're breathing okay, pain meds, all the meds, small frequent meals, positioning, semi-Fowlers. We're going to monitor and maintain our chest tube system. Just FYI, you never clamp a chest tube. All right, this can result in increased air or fluid in the pleural space. This can worsen a pneumo and can lead to a tension pneumo. Again, that's chapter 27 if you're extra curious, but again, not our thing right now. Teaching pursed lip breathing, pacing activities, stop smoking, nutritional needs, meds, pain meds around the clock. People can be resistant to the idea of pain meds around the clock. So that is definitely something we might have to do teaching with. So that is upper and lower respiratory infection stuff, disorders. Thank you. And we're less than 2 hours. We did it. Thank you, guys.